Welcome to Questions That Need Answers. I am your host, Markeisha, and you are tuned in to the Fit and Fabulous Health and Wellness Podcast. Tonight, I am joined by two fabulous women doctors to celebrate March, which is National Women's Month. Today, we're joined by Dr. Tanya H. Evans. Dr. Tanya Evans studied biomedical engineering at Southern Methodist University. In 2005, she graduated from University of Texas Southwestern Medical School. Then she completed her residency training at Texas A&M Scott and White in 2008. Following this, she completed her fellowship training in gastroenterology at Baylor University Medical Center in 2012. She and her team at Texas Digestive Disease Consultants have maintained a practice for over 10 years centered on individualized digestive care and wellness. She also serves on the board of directors at Texas Endoscopy. Her areas of interest within GI are colorectal cancer screening and women in health. And away from the office, she is a wife and mother of two and enjoys interior styling. Ladies and gentlemen, Dr. Tanya Evans.
Thank you so much.
Also joining us is Dr. Lynn O'Connor. Dr. O'Connor earned her master's degree in public health at Yale University and her medical degree from Temple University School of Medicine. She completed her general surgery residency at Union Memorial Hospital in Maryland, followed by a fellowship in radiation oncology at Johns Hopkins Hospital. She culminated her training by completing a fellowship in colon and rectal surgery at the Georgia Colon and Rectal Surgical Clinic in Atlanta. And of course, her bachelor's degree is in biology from Rutgers University. Along with helping her patients, Dr. O'Connor is a noted lecturer, speaking nationally on advanced techniques related to minimally invasive colorectal surgery, colon cancer screening, and colorectal health. She has published multimedia and peer-reviewed journal articles and has been featured in many media outlets, including NBC News, SiriusXM, TheTodayShow.com, and Men's Health Magazine. Most recently, Dr. O'Connor has been named Section Chief of Colon and Rectal Surgery at Mercy Medical Center and St. Joseph Hospital in New York. Welcome, Dr. O'Connor. Thank you so much for joining us today. Now, what I like to do is start off with a little quiz. So we have a few questions here that pertain to colon cancer. So are you ready for the quiz? All right. Here are some questions that need answers. So question number 1. What cancer is the third most common cancer in men and women? Is it A, lung cancer, B, breast cancer, B, prostate cancer, C, breast cancer, or D, colon cancer? What is the third most common cancer?
I'm going to go on a limb and go with D.
D is correct. Colon cancer. Question number 2. Regular screening for and removal of colon polyps reduces the risk of developing colon cancer by A, 25%, B, 50%, C, 75%, or D, 90%.
Good point.
I'll say 75%.
The correct answer is 90%.
Okay.
90%. Okay, on to question 3. Which is the only screening test that allows both identification and removal of colon polyps? Is it A? I'm sorry?
Sorry, well, I should let you read this.
Well, you said it. What did you say?
Colonoscopy.
You got it. A colonoscopy. That's right. Very good. Which of the following are risk factors for colorectal cancer? Is it A, family history, B, cigarette history, C, obesity, or D, physical inactivity?
Well, all of these have some potential association.
That's correct. Very good. All right. Question number 5. This is true or false.
True.
Being African American is associated with an increased risk of colorectal cancer. Is that true or is that false?
True.
Unfortunately.
That is true. Correct. That is true. Individuals born around 1990 have twice the risk of colon cancer than those born around 1950. Is that true or false?
True.
That's false.
It's true.
It's true. All right. Question number 7. Excuse me. All of the following may be signs of colon cancer except, are there no symptoms at all? A new unexplained anemia, a change in bowel habits or stool caliber, or blood in the stool or rectal pain?
All of these can be symptoms.
Yeah.
That's correct. All are true. Number 8. Men have a 1 in 23 lifetime risk of colorectal cancer, while women have a 1 in 25 lifetime risk. Is that true or false?
It's true.
That's true.
That is true. That is true. Very good. Next question. If you have colon cancer surgery, you will have to have a bag or an ostomy. Is that true or false?
False.
That is absolutely false. Very good. Last question. The recommended age to start colorectal cancer screening in average risk patient is 35, 45, 55, or 65.
Now B, 45.
45 is correct. That is right. Oh, looks like we have a bonus question. Which of the following were diagnosed with colon cancer? Chadwick Boseman, Daryl Strawberry, Eartha Kitt, or Kango Kid of UTFO?
All of the above.
Yeah.
All of the above. Very good. Very good. Thank you so much for participating in our question and answer period. Now let's dive right into some very good questions that our listeners want to really know. So, Dr. O'Connor, the first question is for you. What are the early symptoms of colon cancer?
Well, that's actually a really good question, and the way you phrased it is important as well, too, because there are no really, quote, early symptoms of colon cancer. You really want to do screening before you have a cancer. And the purpose of screening is to remove polyps before they become cancerous. And if you are screening and you do find a cancer with no symptoms, then that's an early cancer. Usually when you have symptoms, it means that the cancer is more advanced. And that would include some signs and symptoms such as rectal bleeding, change in bowel habits, weight loss, abdominal pain, early satiety where you're feeling full. Those are some of the common symptoms that you would find in someone who has colon cancer. And those symptoms are usually present when the cancer has been advanced.
Thank you so much. And Dr. Evans, a question that came in just recently was, how can you lower your risk of developing colon cancer?
Well, first and foremost, I think it's important to lower your risk for a lot of ailments by living a healthy lifestyle, right? Getting good variety in your diet with high antioxidants, moving, being purposeful for your movement, but also getting your screening when it's time and knowing your family history can be helpful as well.
All right. And why is the survival rate of colon cancer in African Americans lower than other races? And I'd like to hear both people's opinion on this question because, in our race, we're more prevalent to have colon cancer. So, Dr. Evans, I'll start with you and then I'll go to Dr. O'Connor.
Sure. It's multifactorial. I think there are many factors that kind of go into not only mortality, but also just overall incidence. Part of it is access to good screening. Part of it is, did your primary doctor actually refer you for a colonoscopy? Part of it is genetics. I think there's some more recent research that shows that there's a higher incidence of right-sided colon cancers in our population, and that probably stems from some genetic mutations. So I think it's multifactorial.
And can you piggyback on that, Dr. O'Connor? Yeah, I would agree. I think it's all of that, and there's healthcare disparities. Where you have physicians that are not aware of some of the ethnic, racial disparities and distribution in the incidence of colorectal cancer. I think also on the patient part, there's misconceptions about the procedure. There's mistrust of the medical community. A lot of people sometimes think that I feel well. So if I feel well, why should I have a colonoscopy? When you couple that with the possible lack of insurance and the food deserts that we live in certain areas of the underserved community that happen to be more densely populated with black and brown people. You start to look at their risk factors, you start to look at their comorbidities, and all of that factors into their mortality. And you have that coupled with poor access, poor screening rates, poor follow-up, and their inability to be able to afford care at times. All of those things amount to that. And they're not getting screened. 1 in 3 Americans who are eligible to get screened are not getting screened. So if you're not getting screened, you cannot get those polyps before they become a cancer, and you can't find the cancer before it becomes it becomes more advanced.
And speaking of screening, can you tell us what the difference is between the Cologuard and a full colonoscopy? Dr. O'Connor, we're seeing the commercials on TV about get your Cologuard and all of that. Can you describe to us what the difference is?
Yes, the difference are when you're looking at a colonoscopy is the only modality that is both diagnostic and therapeutic. Diagnostic meaning you can find a polyp, therapeutic meaning you can remove it. And when you look at and as we said, in certain hands, the detection rate is up to 90%. But when you look at Cologuard looks for DNA, stool DNA, and hemoglobin. And it is 92% accurate for colon cancers, but it's only 42% accurate for colon polyps or adenomas. And the whole purpose of screening is to make sure that you get these adenomas before they become a cancer. So, I always tell my patients the best test is the one that's done. But if you have to choose between a Cologuard and a colonoscopy, I always tell them, if you're medically fit, I would have a colonoscopy.
Okay, that's good information. Now, Dr. Evans, we're seeing people get diagnosed with colon cancer that are younger and younger. What are you seeing with the younger patients that are getting diagnosed?
Well, it's unfortunate, but if you're diagnosed younger than the age of 50, you tend to have a more advanced presentation. I think it's partly because we're not necessarily expecting the younger population to be at risk. Also, it's easy to ignore certain symptoms that are going on. I probably see it every day in my practice: rectal bleeding, treated as hemorrhoids, ignored. I always think any type of rectal bleeding should be identified, even if it is something benign. But partly because the DNA and the genetic mutations are more advanced, and then the presentation is further along once people get diagnosed.
Okay, all right. So we're needing to go earlier than 50, right? We need to go when we're 45.
Correct.
Right? And so why is the myth so big around the ostomy bag? We saw on the test that you don't necessarily get an ostomy bag when you get diagnosed with colon cancer, right? But when does the ostomy bag come in?
The ostomy bag comes in on several reasons, and it's really judgment of the surgeon, the presentation of the patient, and the conditions in which you are operating. Most times, when you are operating on a patient with colon cancer, you don't necessarily need to give the patient an ostomy. An ostomy bag may be necessary if a patient is presenting in an emergent situation with a colon cancer that's obstructed and you cannot clean out before you have surgery, or there's a perforation, the colon ruptures, and the patient is extremely sick and you can't put the colon back together because they're so sick. There are other options also when a patient may have a very, very low rectal cancer. And if the rectal cancer is involving the sphincters, and those are the muscles in the anus that keep us continent and keep us social. And if the cancer is involving that area and it cannot be cleared to where you have good margins, then we do something called an abdominal perineal resection. And that's when we take out the rectum and the anus, and the patient would have a permanent colostomy. Most colostomy bags, if they do have to, if they are there, then we can reverse them, and it's anywhere from 6 weeks to 3 months, or maybe a little bit later after the patient has healed. For instance, if we do what we call an anastomosis, where we cut one part of the colon and another part of the colon, and it's very low down, in order to protect where we sew the patient or staple the patient back together, we may give them a temporary ileostomy, and that's the small bowel rather than the colon. So there are some instances where a colostomy can be life-saving. There are some instances where a colostomy is permanent, and there are a lot of instances where a colostomy is temporary. But just because you have colon cancer does not mean you will have an ostomy bag.
All right. So I wanted to dispel that
That is
myth about the ostomy bags. So many people are afraid of getting the ostomy bag, and that's why they don't go get the colon cancer screening.
That's the first
So
thing people ask me when they have a problem. Am I going to have a bag? Am I going to have a bag? And it's a weird, it's an uncomfortable situation, and it's an undesirable situation, but that's what's really highlighted the most. So that's what people focus on. And that's always not the case.
Very good. Now, Dr. Evans, are there any other digestive diseases that could lead to colon cancer, or are there digestive diseases associated with colon cancer prevention?
Sure. So there are certain conditions where you'll be at higher risk for colon cancer. So, for example, if you have, chronic underlying inflammation, whether it be colon involvement from Crohn's disease or ulcerative colitis, these conditions can increase your risk. For colon cancer screening, those are individuals that we would screen more frequently. And then really family history, right? So if there is a personal or a family history of a hereditary genetic mutation, that would put patients at increased risk. And that would be also a population where we would want to screen earlier and screen more frequently.
Now, let me ask you a question because I heard something earlier that kind of sparked my curiosity. What is the difference between colon cancer and anal cancer, Dr.
Oh,
Evans?
that's a great question. So your colon is a fairly large, long organ that basically helps you reabsorb all the water that your upper intestine will make through the digestive process, whereas your anus is a very short portion at the very end. And anal cancer comes from different types of cells, so very similar to the skin cells, basically, versus the internal intestinal cells, which is colon cancer. Would you like to expound upon that, Dr. O'Connor?
And they're treated differently as well.
Yeah, right. So it's important to distinguish.
Anal canal cancer, where it's within the anal canal, and then you have anal squamous, where it's on the outside. You can have it on the outside. That's surgically removed. The anal canal cancer is treated with chemoradiation at times. And the colon cancer, usually we don't treat with radiation, we treat with surgery. So it's different locations, it's different treatment modalities, and sometimes it's different presentations.
Very good. Very good. It is colon cancer month, but we also want to talk about women because we know that March, we're almost to the end of it, but it's also Women's Month. It's all about us, the woman. I am woman, hear me roar. But I want to focus back on the two of you. You're very successful women, doctors in the field of colon cancer. Can you tell me about how you came up through the ranks, Dr. O'Connor and then Dr. Evans? Just tell a little bit about how you became a digestive disease doctor.
So I'm a colorectal surgeon, and I overlap a little bit with the gastroenterologist because we both do colonoscopies. But I always knew I wanted to be a physician. I just wasn't sure that I wanted to be a surgeon when I first started out. I thought I was going to be a pediatrician. I realized I like healthy kids. I can't. It breaks my heart to deal with sick kids. And I went through all of my rotations, and the one that really stuck with me was surgery. I love the fact that you could affect change immediately. I love working with my mind and my hands. And there was nothing else that I could ever see myself doing. Once I got into my general surgery residency, I loved working on the abdomen. I like mysteries, and the abdomen is a black box. And I wanted to focus on one area and do that one area well. And colorectal cancer screenings and anorectal cases and colonoscopies, the whole entire colorectal area is one discipline, one specialty where you can really affect change. You can do it on so many levels. There's a lot of education, there's a lot of prevention, there's a lot of patient empowerment that goes into that. I'm very passionate about healthy eating, nutrition, exercise. Those are all the things that go into preventing colorectal cancer. So I'm marrying my passions and I'm marrying my profession, and that's how I became a colorectal surgeon. In addition to that, I did not like the way certain things were done in corporate medicine, and I decided to have my own practice. And in starting my own practice, I have a lot of time to, I can parse my time out the way I want to do that. So I can be involved in industry, I can be involved in academics, I can be involved in the hospital, and I can be involved in my practice. And more importantly, I can spend more time with my patients. So those are the things that were extremely important to me. And that's kind of the path that I took to get where I am.
Very good. Dr. Evans?
Yes, that's, I think, great, fascinating. It's so awesome that you get a chance to have a little bit more control in that in your environment. For me, I think I too knew at a young age that I wanted to do medicine and become a doctor, but was not sure exactly what type, and was probably a little less straightforward path, just having little insight as a young person as to what would really fit well. But I've always had an interest in nutrition. I've always had an interest in digestion, and kept telling all my friends in medical school, you should do GI, you should do it, not realizing that maybe that meant I might be interested in it. But yeah, just like Dr. O'Connor mentioned, I think every patient, deserves someone who is passionate about what they do. And when I really thought about that, that's kind of what pushed me to go ahead and specialize in digestive health. So I get to see patients and encounter patients with digestive issues daily and help them come up with personalized solutions to wellness. And so a little less straightforward path. Went through internal medicine, was chief resident, but eventually landed in GI. And I love being able to be a part of a community where we get to see a variety of patients with a variety of ailments and do have the potential to save lives every day.
Well, we love to see women of color and especially women, healing our community. Because like we said, colon cancer is prevalent among African Americans. And we do have to take care of our bodies. We have to take care of our bodies from the inside out. And I just appreciate both of you being on the front lines, addressing this issue. So I just want to see if any one of you, Dr. O'Connor, Dr. Evans, if you would like to have final words about colon cancer screening, colorectal cancer, digestive diseases, final words from you, starting with Dr. Evans, and then we'll continue on with Dr. O'Connor.
I think my final words are just to stress the importance of screening, appropriate screening, knowing your family history. I think every day I encounter someone who didn't know that if your sister had polyps, that meant you had a higher risk and that you should get screened earlier. And then also to maybe destigmatize, colon cancer screening. It's a life-saving procedure, and the preparation involved with it is not what it used to be. It's significantly improved, and the procedure is relatively low risk. So why not get your tune-up when it's time and keep yourself going? Good screening colonoscopy.
And I think that's absolutely appropriate and right on point with what Dr. Evans said. I would only add that I think we need to take responsibility for our health and we need to advocate for ourselves. If you do find that there are some symptoms that you're not sure what's going on, if there's any rectal bleeding, or change in bowel habits, abdominal pain, something that you just don't think is right, you need to push for your examination. You need to push for your colonoscopy. If you're a young person or you know and love and care about a young person and they're having symptoms, the majority of those young adult onset colorectal cancer patients are mismanaged and misdiagnosed because nobody is thinking about that. And as these rates go higher and higher and higher, that has to be more in the forefront of our differential diagnosis and our thought process. So if you do know someone like that, urge them to get care, urge them to see the physician or take them. And the last thing, if you go get screened, go bring someone with you and go get screened together, because screening colonoscopies save lives and it takes a village.
Well, I want to thank you ladies for joining me tonight. This has been the Fit and Fabulous Wellness, Health and Wellness Expo podcast. I'm your host, Markeisha. Dr. Lynn O'Connor, thank you so much. Dr. Tanya Evans, thank you so much. And we'll see you next week on Questions That Need Answers. Good night.